Patient is a 40-year-old female that started complaining of left flank pain 2 days ago. She was seen in the emergency department where she was diagnosed with kidney stones and was subsequently sent home on antibiotics and pain medications. She returned to the emergency department today with worsening back pain, fever of 103, chills, nausea, vomiting, back pain, as well as difficulty breathing. Her oxygen saturation in the ER was at 85% on room air, requiring supplemental oxygen. Her initial blood pressure was 132 over 69 when she arrived to the ER, but subsequently dropped to 90 over 60. A CT angiogram with PE protocol was done to rule out pulmonary embolism, which it was. There was no focal pulmonary infiltrates. She was found to have a urinary tract infection with right obstructing hydronephrosis secondary to nephrolithiasis. She did receive crystalloid fluid resuscitation. Cultures were obtained, and she was started empirically on a combination of ceftriaxone and Sozin as well. Um, Her blood pressure continued to drop, so much so that she was given a left internal jugular central line and was started on a norepinephrine drip. She was admitted to the ER. Past medical history is polycystic ovarian syndrome. She has a surgical history of a C-section. She is Grava 2, Para 2. She is not allergic to medications or food. Her family history is only positive for a maternal history of nephrolithiasis. She is married. She is a kindergarten teacher, um, does not drink alcohol or smoke cigarettes. A review of systems revealed no pertinent positives except for the history of present illness. Physical examination. Currently, the temperature is 99.8. Her heart rate is 94. Respirations are 24. Blood pressure is 132 over 78. SpO2 is 89% on 4 liters. Um, she is moderate respiratory distress, saturation, as noted, on 4 liters. She does display increased work of breathing. She is awake and alert, but in moderate distress, secondary to pain. Her head, she is normocephalic, no signs of head trauma. Her eyes are perla. Conjunctiva is normal. There is no discharge. ENT, her hearing is grossly intact, normal oropharynx, dry mucosa. She is a Malampati 3. Her neck is supple without any tenderness, no lymphadenopathy, no thyromegaly, no bruise, no JVD. There is that right jugular triple lumen catheter in place with mild blood around it. Biopatch in place. The lungs are clear. Breath sounds bilaterally. There's no wheezes, no rales, no rhonchi. Um, she does display that increased work of breathing. Her heart, she is tachycardic, regular rate and rhythm, normal S1 and S2 without any murmurs, rubs or gallop. Vascular, she has no edema, no her peripheral pulses are normal and equal in all extremities. Her abdomen is obese but soft with mild tenderness. GU is normal. Her she displays no lymphadenopathy. Her extremities are within normal range of motion. There is no joint swelling, no clubbing, no cyanosis. Her capillary refill is at 2, and her nail bed is pale. Skin, she has no rashes or lesions. She is alert and oriented times three with a normal affect. Cranial nerves are intact. There is no focal, sensory, or strength deficits. Her reflexes are also intact. Her lab work pertinent positives are white blood cell count is high at 17.28. Her H&H is low at 7.6 and 25.8. She does have lymphocyte elevation at 14.98. Her sodium is at 150. Chloride level 113. She is got an elevated BUN at 35. Her phosphate is low at 1.8. Radiology studies are pending. We are going to repeat a chest X-ray as well as a CT, chest, abdomen, and pelvis. We are pending that assessment. This is a 40-year-old female with septic shock due to complicated UTI, which she acquired outside of the hospital with obstructive uropathy, left hydronephrosis due to kidney stone. The stone is approximately 4.5 millimeters left distal ureter stone. Patient has evidence of volume depletion, acute kidney injury, and acute hypoxemic respiratory failure, likely attributed to atelectasis and high respiratory demand due to septic shock. The plan will be to admit to the ICU, consult neurology. She may need a cysto with drainage if possible, versus nephrostomy. We will do IV fluid stewardship, continue to cover empirically with Zosyn and Vico, still pending culture and sensitivity. We will do VTE prophylaxis. We will replace her potassium and fix all other electrolytes. We are anticipating that the patient will probably need endotracheal intubation and mechanical ventilation. We are discussing that with her and her family currently, and possibly consult surgery. This is all due to her respiratory distress, her metabolic acidosis, and septic shock. Patient will remain in the ICU, and we will follow up subsequently.